I want to convince you that getting an investigation or scan, radiography, imaging, whatever you want to call it, is probably not the best course of action for most musculoskeletal conditions. I'm talking things like knee pain, neck pain, shoulder pain, but most especially for lower back pain. Hey YouTube, how's it going? My most recent Instagram post is titled "Why Scans Can Be Harmful" for lower back pain. Here I go over a clinical commentary that was published over 10 years ago, titled "The Appropriate Use of Diagnostic Imaging in Lower Back Pain, a reminder that unnecessary imaging may do as much harm as good." Let's read it together and I'll explain as I go along. Back pain remains to be one of the largest burdens of disease, accounting for 50% of all patients seeking outpatient physical therapy care. This is why we have so much research being done on lower back pain, because even still till this day, it is the number one most common musculoskeletal complaint, according to statistics around most of the world, that is seen by physical therapists. Lumbar imaging and subsequent surgeries are continually increasing year by year. But so long as red flags and sinister pathology have been ruled out, things like cancer, infection, fracture, neurological fallout, etc., scans are rarely helpful and sometimes even harmful. It is so alarming that we continue to see the medicalisation and over-treatment of lower back pain, even though research data and clinical guidelines have been available for decades at this point, that say that we shouldn't be sending non-specific lower back pain cases for imaging. It is standard practice by physiotherapists, medical doctors, and surgeons to screen patients for more serious medical conditions. But if our index of suspicion is low, then in most cases there's no need to infer more costs by referring them for further investigations. There is no difference in pain, function, quality of life, and overall patient-rated improvement between those who are provided usual care without routine lumbar imaging and those who are provided usual care and the addition of lumbar imaging. So in this systematic review and meta-analysis, they compared patients who received treatment based on their findings on investigations from X-rays to MRIs to CT scans versus patients who received treatment with no imaging. And at the end of it all, their outcomes, their pain, their function, their quality of life were not statistically significantly different. This is a common theme that you will see amongst most lower back pain research of a similar nature. Diagnostic imaging in individuals with back pain should only be used if the results of the image lead to clinical decisions that result in improved patient outcomes. If your healthcare provider is up to date with clinical guidelines, then they should know which conditions management will change according to the result of certain imaging and which won't. Moving on to part 2, MRI can in fact facilitate the medicalisation of back pain. Like I said before, many pain-free individuals will have pathological findings on an MRI, and many of these pathological findings are just normal age-related or degenerative changes. And there have been so many studies that have shown this time and time again, but not just with lower back pain. Even things like X-rays used for knee osteoarthritis or ultrasound used for rotator cuff tears in the shoulder. Most of these pathological findings are just general age-related degenerative changes that we see in normal pain-free individuals. So, for example, in asymptomatic people 60 years and older, so these are pain-free individuals with no loss of function, asymptomatic, experiencing no symptoms, 36% had a herniated disc, 21% had spinal stenosis, and over 90% had a degenerated disc or disc bulge, according to this study. Where this starts to become a problem is because pain and injuries are so damn multifaceted and complex that they can't be attributed to one singular cause. If somebody has back pain and goes for an MRI, it is incredibly likely that that MRI will come up with some type of pathological findings. But it's also very likely that that pathology was present before the patient had pain in the first place. So when a doctor or surgeon recommends surgery based on these findings, are they really addressing the problem at hand? We don't know. Here's another example. According to this paper, MRIs were performed in over 200 pain-free, asymptomatic patients who were followed over a 5-year period. They then repeated the MRI if the patient had developed an episode of back pain. 84% had unchanged or improved lumbar imaging abnormalities after symptoms had developed. And at baseline, so when they had no pain, there was still a high incidence of what would be considered potentially serious pathology, despite all subjects having no pain. So just like I said previously, many of these patients already had findings before they developed pain, and for 84% of them, nothing changed after they had developed pain. In fact, some of the imaging findings even improved after their episode of lower back pain, which is absolutely mad. And in this example, this study, just to show you how MRIs can increase the medicalization of back pain, they performed MRIs on patients versus X-rays, and it had shown that those who had MRIs resulted in a 3-fold increase in surgical rates with no improvement in outcomes in the subsequent year. So the group of individuals with low back pain who had received an MRI over an X-ray were 3 times more likely to be recommended for surgery. But the outcomes for those who had surgery versus those who didn't have surgery yet again were the same. Unnecessary lumbar spine surgery is costly and has significant side effects, including death. Life-threatening complications are particularly common in older individuals, ranging from 2.3% amongst patients who are having compressions alone to 5.6% amongst those having complex fusions. Surgery for most musculoskeletal conditions should be somewhat of a last resort scenario, which greatly depends on the severity of the condition itself and how much disability or lifestyle disruption it is causing. In most cases, it simply isn't worth the cost, the time needed to take off work, the time needed for recovery, the trauma, the risk of adverse or side effects of medication, and at the end of the day, the chance that the surgery doesn't even help. To date, there is no evidence that selecting therapeutic interventions based on the presence of common imaging findings in people with non-radicular lower back pain improves outcomes. So people who have back pain that is not related to radicular or nerve-related symptoms or nerve root impingement, that type of thing. Basically, interventions that are chosen according to investigations have no change in outcomes. And the final point, or the final part, telling patients that they have an imaging abnormality has negative effects related to labeling. For example, in this paper, MRIs were performed on 246 patients with acute lower back pain or sciatica. They were randomized to receive results on the imaging or to not receive the results. After 1 year, both groups had similar clinical outcomes, but the self-rated general health improved significantly for those that remained blinded to the results of their MRI. This is likely due to the negative side effects associated with labeling. Those who are told that they have pathological findings from an investigation may suffer from further psychological distress, with the thought that something is wrong with them, something is broken, or something needs to be fixed. This causes grotesque mental imagery and reinforces the perception of fragility within the patient, causing them to avoid certain movements, tasks, or functions, and to further catastrophize their pain. And in this last example, patients with back pain received either a booklet about their condition or they had to watch a video with actual patients describing their preferences and their decisions about the surgery. Patients who had watched the video as opposed to the booklet were more knowledgeable about the surgery and were also less likely to receive surgery or less likely to opt for surgery. At a 1-year follow-up, yet again, the patients who decided against surgery had the same outcome as the patients who had the surgery. Thus, surgical rates were reduced without adverse outcomes. And so yet again we see that patients who opted for surgery and those who didn't have surgery had the exact same outcomes. But we also see that when patients are adequately educated about their condition and their surgery and fully understand the risks involved with the surgery and the consequences of not getting surgery, they were more likely to just not want it. This is what we call informed consent, a basic human right and medical ethics principle that is often, lost along the way during most patient interactions with doctors and surgeons. And it is not stressed enough or done enough by medical providers. MRI results are not reflective of serious pathology. There are many cases where elderly individuals appear to have the proverbial spine of an 85-year-old on a scan and yet still enjoy a robust physical lifestyle. And then on the flip side, some younger individuals have zero findings on a scan while presenting with some pretty severe debilitating episodes of lower back pain. When used appropriately, diagnostic imaging is an important component of patient care in individuals with back pain complaints. The inappropriate use of lumbar spine imaging can increase the risk of patient harm and contributes to the recent large increases in healthcare costs. Therefore, it is important to educate patients and medical colleagues on appropriate imaging and the integration of imaging findings in the overall context of a patient's function and disability. That is it. Thank you for watching. Let me know if you have any questions, concerns, comments, or critiques, and leave them down in the comments below. I'll see you in the next one. My name is Bradley Cato, and thank you for watching yet again. Peace.